Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of patient care through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in ophthalmology and optometry. Our mission is clear: empower eye care providers with the knowledge and tools needed to deliver exceptional patient care. The Advanced Patient Care podcast is dedicated to elevating our craft, one episode at a time.
Hello, everybody, and welcome to this episode of Advanced Patient Care, the podcast from Vance Thompson Vision. I've got some wonderful guests with me today. I'm Mike Greenwood. I'm a surgeon up in Fargo, North Dakota, and I'll introduce my guests. We'll go around the horn. We'll start with you, Kelly.
Hey everyone, I'm Kelly Seeps. I'm an optometrist at Vance Thompson Vision in South Sioux City.
And Jason.
Hi, good morning. Yeah, I'm Jason Schmidt, optometrist with Vance Thompson Vision in Alexandria, Minnesota.
And last, but certainly not least, Vance.
In Vance Thompson, I practice refractive and cataract surgery in Sioux Falls, and honored to be here with you all.
Well, thank you guys for taking time out of your day to talk a little bit about refractive surgery, and specifically we'll talk about refractive lens exchange, but I'll go back to what I mentioned with refractive surgery. And when we hear refractive surgery, and those that have been listening or practicing, or maybe have been a patient yourself, when we say refractive surgery, the first thing that pops into everybody's brain is LASIK. And so we've done different seminars and podcasts and talks on LASIK, and we've talked about PRK, which has been around, even longer. And Vance, you were there at the forefront of all of the refractive surgery, but refractive surgery itself with PRK. And then comes along the SMILE procedure, and then Visian ICLs. But one that probably doesn't get talked about near enough and doesn't even come to mind is refractive lens exchange. And Vance, I guess I referenced you. I'll start with you. Do you want to kind of talk about why just what is a refractive lens exchange? What am I even talking about?
Well, thanks, Mike. And I always think of refractive surgery as wanting to take kind of a comprehensive approach to every consultation. Should we, recommend corneal refractive, phakic IOL, or lens replacement, or is it best for the patient to do nothing because we know glasses and contact lenses work great? And, one of the things that we've learned over the past, few decades of lens replacement research for cataract surgery, when we look at things like trifocals and light adjustable lenses, is patient satisfaction has gotten so high in that cataract surgery arena when we address both the clarity and the reading range that some patients are saying, do I have to wait for a cataract to get the benefits of lens replacement and address this thing, called presbyopia? Do I have to do monovision, or, can I go for good distance, good computer, and good near by addressing the lens? And I think that's one of the things that's increased our refractive lens exchange surgeries, is just happy cataract patients out there and their friends not wanting to wait for a cataract, but also the fact that patients now know there's a way to address presbyopia with, able to preserve that nice distance vision. And kind of my initial thoughts, Mike.
Yeah, thank you. And Jason, maybe I'll ask you this of how, comparing this to LASIK. So Vance, Vance mentioned with a refractive lens exchange, we're addressing the lens. And so we've got, glasses or contacts, and then we've got the tear film, and then we've got the cornea, and the lens. So Vance talked about, I led him into talking about the lens, taking your lens out. Jason, I'll ask you, what makes this different than, LASIK or something cornea based?
Yeah, right. So when patients are coming in looking for solutions for vision correction, whatever that might be, LASIK has been around a long time. I had LASIK back in the day, and I loved it. It's great. But when I think of patient solutions today, I think of what am I going to be able to do today that will still allow them options in the future. And so when we get into these older folks that are in their, middle, late 40s, 50s
Yeah.
and older.
Careful with the
Yeah.
the word older.
Hey, I'm in that group. I think of, if LASIK still might be an option, but is it going to allow them future options with lens-based surgery in the future? So I got to kind of take the full scope perspective of trying to figure out what can work today, but what will also allow them options in the future. And so sometimes that might mean not doing LASIK and thinking about something in the eye.
Yeah. And I'll back up well, let's go into this. You talked about it a little bit of why it's growing, why RLE is becoming a little bit more popular. Vance, you talked about how much success we've had with cataract surgery and the technologies that come out and why like that's been so good. And so Kelly, maybe I'll pin this over to you of what are these people looking for that are coming in for refractive lens exchanges?
I think most of these patients are just looking for independence from glasses or contact lenses, as is the case for other cornea-based refractive surgeries as well. But traditionally, those surgeries can only fix a patient's vision at one distance. And so, whereas we've had monovision as an option for these patients in the past to, give them as much freedom as we can, there are downsides to that. And so, being able to offer these patients lens technologies and lens-based solutions that allow them more of a full range of vision in both eyes can enhance the clarity and quality. And I think the benefit of that is too, they're not going to need cataract surgery down the road. And so, they're looking for a long-term solution, and cataract surgery remains stable for a long period of time. So,
yeah, and great point about not needing a future surgery with cataract surgery. And so who who would be a great candidate for refractive lens surgery? Jason, you touched on you've had LASIK before. So would a 20-year-old patient need refractive lens exchange?
Yeah. So maybe, I think some of the high hyperopes, when there just isn't any other option, those are the ones that we might consider something like that for. But typically it's a myopic patient, middle, late 40s, early 50s. Those are the kind of patients that we have these discussions for, because like Kelly said, we can allow them to, correct both their distance and their near vision and their intermediate vision, really all ranges, and possibly even save them then from a future surgery, because we can do it all at once. And then one surgery will last them forever.
Yeah. So a 20-year-old, they're wearing contacts or glasses, but their natural lens inside of their eye is still able to bend and flex, zoom in and out on certain things. So they don't really need that presbyopic correction.
Yeah, so someone in their early 20s to 40s, those are the patients that we probably wouldn't necessarily consider that for if they're myopic. Like I said, some rare cases we might consider something like that for a high hyperope that there just isn't any other options. We can't do cornea-based surgery. They don't really make a good phakic IOL, and so maybe a lens-based surgery would be a consideration for that.
Yeah, and so we've kind of the mindset of eye care is sort of shifting from just do LASIK. I'm saying cornea-based refractive surgery. I'm using LASIK again as a generic term, like we mentioned at the beginning. But if you're 20 and you want to get out of glasses or contacts, it's LASIK. If you're 30, it's LASIK. If it's 40, it's LASIK. If you're 45, it's LASIK and you're going to need readers. If it's 50, it was LASIK and you're going to need readers. If you were 60 and you didn't have a cataract yet, but you wanted to get out of glasses, it was LASIK and you're going to need readers. And then the cataract would, come after that. And so now we've got this opportunity in these, like you said, Jason, kind of the middle, I'm going to call it the middle age, the sweet spot, because that's kind of where I'm approaching. But the 40-ish year olds to the pre-cataract, 55-year-olds, that we can take out their natural lens and put in an artificial lens. But we've been able to do that for years and years and years, with cataract surgery. Vance, you touched on it just a little bit, but why, or sorry, maybe it was Kelly. Why all of a sudden is it so much more advantageous to do refractive lens exchange in this population versus LASIK?
Well,
and I'm kind of leading you, so.
We all know that the happiest patients are the ones that we give full range vision to. And it seems like the happiest, corneal refractive or phakic IOL cases are the ones where their accommodative mechanism works great. And so once that accommodative mechanism starts to deteriorate, patients are enjoying hearing the options of not only taking care of their refractive error, but also their presbyopia. And we even have some coming in with no refractive error, just presbyopia, because they want that full range vision. And so, for me, it has a lot to do with how our world has moved to computer and cell phone driven. And so patients are really enjoying the convenience of restoring that full range vision of their younger years. And so the high patient satisfaction of, modern day implants and cataract surgery, again, have these patients saying, "Gal, do I have to wait 10 to 20 years for a cataract? Can I go ahead and have my lens replaced now?" And it's the fastest growing area in refractive surgery because of the modern day implants. And also, even some of the patient education stuff that we're doing about the fact that people can have full range vision, and we can simulate that for them.
Yeah. So this is a great time for a break and kind of moving into our next steps. And so let's move on to kind of the whole process of, what it means to have a refractive lens exchange, starting from maybe even just the education, like you said, Vance, and then we'll kind of work our way through the evaluation, the technology that we've kind of touched on, and any other tidbits that come in there. But I think just to kind of summarize what we talked about before is a younger person, 40 plus or minus 10 years on each side of that, who's looking for full range of correction, who's starting to have some issues with near, and including their distance vision. And the reason why it's become so much more popular recently is kind of a three-headed monster with the way the world is moving, with our technology being kind of more in this near intermediate range than it ever has been, and the safety and efficacy of the surgery and the implants themselves. So let's go, Vance, you kind of touched on the marketing opportunity and just more awareness of people not knowing that it's available. And so, Kelly, when people come into your practice, how often do you think they know that refractive lens exchange is even an option, or are they coming straight in saying like, "Hey, I want LASIK"?
I think it's maybe not as popular as LASIK is right now. Most patients have friends or family members that have had LASIK, and they're coming in and they're asking, "Well, is LASIK an option for me?" And, for the most part, that answer is yes, but there are patients who maybe have too high of hyperopia, or who are interested in, refractive surgery to get out of glasses, but have been unsuccessful with monovision in the past. And so I think, LASIK is it's more common and more popular. And so it's us, and I think the OD's role as well, to learn that this may be an option for some of those other patients who in the past maybe haven't been a candidate for cornea-based refractive surgeries.
Yeah. Jason, when say you've got a 50-year-old patient who's, never worn glasses their entire life until they needed readers. They're like a +1 hyperope. So 50-year-old +1 doesn't really wear glasses for the distance, for sure needs them for the up close. And they say, "Hey, I want to have LASIK." And you say, understandable, but how about this refractive lens exchange? What's their reaction?
Yeah, it's probably one of, I didn't know this option existed, first of all. But I think it's just our job is to educate them on, what's happening with the eye. Why are you losing your near vision? What's the next step, developing cataracts in your 60s and 70s, that you're going to need a lens surgery at some point in your life. And so here's an opportunity to address everything now, and then you just have a longer period to enjoy the benefits of the results of the surgery. I think that's probably going back to what Vance had said. It's the technology. I think lenses have been around to correct for distance and near for a while. We had these accommodating lenses in the past that we don't use as much anymore, but there were options back in the day too. It's just these lens technologies have gotten so good. I remember sitting in doing research studies with Vance and the group on these lenses, and I'd watch these patients come in over and over and over again, and the success has just been amazing. So I think that has really probably driven a lot of us to kind of shift the focus back to having this done earlier as well, just because we know that the outcomes have been so good. But I think explaining that, or understanding the patient's visual needs is the first thing that I do. So, what do you do for work? What do you do for hobbies? What do you do after work and things like that? And just understanding how they use their vision then can help us, figure out where do they land in that perspective. It's something that we want to do now, or do we want to wait? Do they have an early cataract even starting? Where do they land in that picture? Because if they're going to be needing a lens-based surgery pretty soon, then this is a good discussion to have.
Yeah. And so, yeah, like you said, I was trying to think of a good analogy, and all I could think of was like a Dairy Queen grill and chill, where like you go in expecting to get ice cream, and then you realize they got burger and fries there too, and you can get burger, fries, and ice cream. And, so they come in, they're thinking, they don't really know what they want. They just don't want to be in glasses, and they're thinking LASIK is the answer. And then you can explain it to them of, hey, we can get you out of glasses for what you're asking. And here's what the benefits are, and here's what the process is like. So there's probably a little bit of shock, a little bit of nervousness around the procedure itself. But then when you lay everything out and say, hey, we can help with, glasses independence for distance, intermediate, and near, then I think the excitement builds. They get excited about it, and that's kind of the beginning of the process. So then, Vance, maybe dive a little bit deeper on some of these implants. You've probably done it a lot through these various podcasts and talks that you've done. But most patients that are coming in, and they sign up for refractive lens exchange, we can use our regular monofocal lenses. We can use our torics, light adjustable lens, trifocal, things like that. What can you say what your kind of your most common lenses you're using for these, and why?
Well, for me, I like to just kind of analyze, both the patient's goals and expectations, but also their eye. How is their tear film epithelium? How's their, eye health from front to back? But let's say that they want full range vision and they have the right eyes for the various technologies. It seems like for me, I have gravitated towards using modern day trifocal implants. They give balance, distance, intermediate, and near. The patient satisfaction is extremely high. I remember my first trifocal study, when the end of the study, when they were asked the patient-reported outcome of, would you do this implant again, and would you recommend it to a friend or a family member? And 99.2% of the trifocal patients said, yes. I mean, wildly happy, I would recommend it to others. And in the monofocal control group, 89% said they would recommend it. So, to see patient satisfaction so much higher with a modern day trifocal versus a modern day monofocal. And this was, after 6 months of neural adaptation and a good chunk of time. And we all know that people typically adapt to a monofocal implant just fine, but it's not a no-brainer. Patients really like to know their options. So it seems like if everything is good, I'm leaning towards a trifocal. If there is something that isn't just right with their eye, or even let's say their expectations, they don't want to go through the 6 to 12 month journey of a multifocal. They're a little worried about nighttime glare and halos, maybe a little bit more precise personality. That's where the light adjustable lens, I think, becomes, just such a wonderful technology. And so for me, it seems like with modern day, refractive lens exchange, or even people, looking for modern day implants and cataract surgery, it's trifocals or light adjustable lens for me.
Kelly and Jason, anything to add?
I would agree.
Yeah, I agree too. I think those moderate high, mild, moderate, high myopes that we could do LASIK on, that would then potentially change their cornea maybe enough that a future option of a multifocal might be limited. Again, those are kind of the things I think about too, is like, if I could come up with a solution now with LASIK, but it might not help you in the future if we do too much. So that's where I look at kind of the whole picture.
Yeah. And that it's been the same for us in our practice. Modern day trifocals and light adjustable lenses are the mainstay. And it kind of comes down to what you said, Vance, of, what's the health of their eye and what is their preference of activities that they're doing now and what they foresee doing in the future. So now that we've kind of gone through, what it is and the process involved and kind of our thoughts on what lens we're going to pick, we'll go into, kind of some of the patient experience and the concerns. So we talked about, all the upside. One surgery helps with distance and near, no need for future cataract surgery. But what about the other side of the coin? Like, what are some of the things that people are worried about or have concerns about? Kelly, do you want to, what are the questions that maybe patients would ask or doctors would think about in these patients?
I think compared to cornea-based surgeries, the lens-based surgeries are definitely more invasive. You're actually going inside of the eye to remove the lens, which puts patients at higher risk of developing things like endophthalmitis and retinal detachments, which the risk of that is very low, but higher than it is with those other traditional cornea-based procedures. I think the other patients that we keep in the back of our mind when we're determining if a patient is a good candidate for this are high myopes, specifically, again, because of that risk of retinal detachment. Typically, I think the rule of thumb is if they've had a PVD, then they're probably more in the clear as far as being a good candidate. But I think it'll be important making sure to do a good retina evaluation before deciding on a lens-based refractive surgery for those high myopes too.
Yeah. And there's a nice calculator online. We can put it in the reference in the notes, unless somebody on the panel knows it. But you can type in kind of the information and it kind of gives the, some of the generic, retinal detachment risk, whether you're having refractive lens exchange or cataract surgery or anything in between on that. And Jason, I guess before I ask you, Jason, some of the other things. So it's very similar. Our routine is on the surgeon side is basically the exact same as cataract surgery. It just happens, the patient doesn't have a cataract yet, but we're taking out the lens, putting new lens in. So we're still doing the intracameral antibiotics. We're still doing all the prep before and after with the medications to minimize, inflammation, infection, all of those things. So like you said, Kelly, extremely, extremely safe on those fronts. But those are the questions that people are having when they're thinking, man, it's not just the surface of my eye, but it's inside my eye that a barrier that they maybe weren't anticipating thinking about when they're coming in for their quote LASIK evaluation. But Jason, what are some other questions that patients ask or think about?
Well, I try to guide them through just the process of this procedure in general. So, the surgery, it's like a 3 or 4 step process, right? I mean, and we need to kind of get through those 3 or 4 steps to be able to hit a home run in the surgery. And so the first step is obviously just having the surgery. There's still about 30 or 40% of patients that can get a little film, get a little PCO on the back of the lens capsule after cataract surgery or refractive lens surgery, either one. And with these multifocal lenses, that can impact the vision outcome more probably than you would thought on just a monofocal lens. So especially in the center optic. So we look really closely to make sure that the lens capsule is clear. And if they need a YAG laser, that could be step 2. And then the third step is just nailing the refractive outcome. I mean, if there's a little bit of a correction remaining, they might need a LASIK fine tune as the third step. And so if you get through all 3 of those steps, those patients do pretty darn well. Now, I also talk about just the 4th step, which is just adapting to this type of lens, this neuroadaptation. And so I tell patients even from the get-go, you're going to see probably a little bit of glow around some lights initially after the surgery with a multifocal, and you probably see that now. So when you go home, look at lights, you might see a little glow around lights already. And patients do notice that after surgery, but that's something that fades over time. And so as long as they kind of know ahead of time the expectations of maybe having to do a YAG, maybe having to do a LASIK fine tune, and maybe expecting that they're going to see some of that initially that will take some time to adapt to, then you kind of set the stage of what to expect. And I think patients then understand it a little bit better. Some of the simulators that are out there too, and maybe you're going to talk on that, also kind of help demonstrate what vision could be like with a multifocal versus with maybe just a traditional monofocal lens too. So there's some good simulators out there, and maybe you might shed some light on that.
Yeah, I'll just briefly mention it. So Brandon Barton and I, worked on a virtual reality simulator that kind of helps go through these different lenses, especially when it's a newer process for people and they haven't had a chance to think about the different implants. And we do think it's helpful in these cases because it's new. But Vance, we've got a few minutes, but I wanted to ask you about any special patients that pop into your head with refractive lens exchange, and then we're going to get into a very, very, very special patient to wrap up the show.
Yeah. And so, again, I find this is the fastest growing area in refractive surgery, in the implant arena. And if their accommodative mechanism is working great, phakic IOLs, and if it's not working great, lens replacement. And I remember my last surgery session of 2024. So, right, it was actually literally right after Christmas. We had, 5 refractive lens exchange patients that week. And a couple of them were high myopes, like Kelly was talking about. And I actually got a retina consultation and told them, that we really wanted to make sure their retina was happy. Got that clearance, and it's amazing, when those patients, get not only the great uncorrected vision pop, but also get their range of vision back because they're, presbyopic and has been addressed. But those hyperopes, how frustrating hyperopia can be. And you get those, +2s and +3s. I think that's where, refractive lens exchange also really shines because it's, not as easy to steepen a cornea with corneal refractive surgery as it is to flatten a cornea. And so to see the accuracy and predictability of hyperopic refractive lens exchange is really amazing. And I really like how you all have talked about the optimization, journey. We all know that we want to take care of residual refractive error in the capsule, but I also want to put a plug in for that tear film, the most powerful focusing element of our eye. And so optimizing that tear film is super important. But the patient satisfaction with refractive lens exchange is extremely high. Patients oftentimes will even notice an improvement in color. It amazes them that their natural lens was actually causing more issues than they had predicted. That's why I don't like the phrase clear lens extraction. I like refractive lens exchange. But the idea that it's early cataract surgery is something that patients can really get their arms around. And the patient satisfaction with this, a lot of the frustrations that come with corneal refractive surgery in presbyopia are taken care of when we can go for that balanced distance intermediate and near with a refractive lens exchange.
Yeah. I love it. And the story of the five after Christmas probably goes with the seven swans are swimming somewhere. It reminded me, I had a group of five farming friends that all came in for refractive lens exchanges, but one went first. And then when he did well, then they sent the second one and then the third, and then, it was over a course of a year. But Jason, you've had refractive lens exchange. You've had LASIK. I've had ICLs. I forget about the other two on this panel. I think Vance was born with perfect eyes, and Kelly, I think you were too. Yep. So, so Jason and I have had the refractive surgery, but Jason, you've had it twice. So can you tell us about your refractive lens exchange journey?
Yeah. Well, like I said, I had LASIK in 1999. So, you know, shortly after it got approved, I was watching patients. I've been in refractive surgery for 28 years. So I've been watching patients back then with great outcomes after LASIK. So I said, sign me up. So I've had great vision, for 25 years. And then I got into my late 40s and things started to change up close. My distance vision was still fine, but my near vision started to change. And so I had to come up with a solution. And so I was wearing reading glasses again, reading glasses. And I'm like, I just hate this. It's hard for me and for what we do. I'm in slit lamps and I'm taking glasses off and putting them down and losing them. And so it's just glasses wasn't an answer for me. So, to be complete, there's some great eye drops out there, right? And so I tried these pilocarpine eye drops, and those worked okay. They didn't last the full day, and it's something you had to use every day. And so it gave me good intermediate vision, a little bit of up close, but it just wasn't what I was looking for either. I tried a contact lens on one eye to simulate monovision. Maybe that was the solution, to get a touch up on one of my eyes. And it was okay. Again, I think I have such a strong dominant eye. It just didn't really work as well for me. So the last option was refractive lens exchange. And again, watching all these patients come through with these new lenses through the research that we've done over the years, I was like amazed at how the outcomes were. So I said, same thing, sign me up. So it was probably 3 years now, I guess it'd be coming on 4 years, that we did both eyes together. And the very next day, I was out for breakfast and reading the menu. So, and again, I did notice some glare, like I said, around lights initially that has slowly gone away. Or slowly went away, and it probably took 3 to 6 months for that to happen. But your brain just kind of figures this out somehow. And I drive at night. I'm sitting here talking to you guys at the computer. I can see as clear as can be. I can see my watch and things up close on my phone. I get all the distances. I did have a YAG laser on one eye about 6 months ago, and that was the only other thing that I've had after this. So.
Yeah. Awesome story. And thanks for bringing up kind of your history of here's where I was at. I tried these different things and then knew that, the refractive lens exchange was the way to go. And that's very an important point that I think we talked about, but it's always great to reemphasize it. And I also like the fact that you said hey, I got both eyes done, same day. And which is also a nice thing. So well, with that, we'll kind of wrap up. if you want to deepen your expertise in refractive surgery, schedule a personalized mini fellowship at Vance Thompson Vision, and you can join us for hands-on learning and build your confidence in guiding patients toward life-changing vision correction options. We'll do one 10-second sign off for everybody. Again, we'll go around the horn. So Kelly, any last second thoughts?
I think just remembering that this is another tool in our toolbox to help patients, and I'm really excited to see where it goes.
Yeah. Vance?
Yeah, we just want to help patients be the happiest they can be, and if that's glasses and contacts, great. If they're looking at a surgical approach, that comprehensive approach to, is it corneal refractive, phakic IOL, or lens replacement? And lens replacement has really grown, because of the beautiful, research and development that these companies have put into optimizing these implant technologies, and definitely worth your patients hearing about.
Jason?
Yeah, I think, we're here to guide and help patients make the best decision for them. And so we'll be able to see that when we do the tests and analyze the diagnostics and talk to the patient about what their outcomes might want to be. And so depending on what that all evolves to, I mean, we're here to offer really the best solution for their needs.
Yeah. The reason that I got into ophthalmology was the technology and having happy patients, and the technology continues to explode all around us and get better and better, which is just hard to believe. And I'm so glad that we've got these opportunities. So thanks everybody for tuning in, and hope you have a wonderful day.
Thank you for tuning in to Advanced Patient Care, the exclusive podcast by Vance Thompson Vision. Want to learn more? Schedule a personalized mini fellowship at one of our clinics where you can gain hands-on experience and real-world applications tailored to your practice. For more resources and information, visit vancethompsonvision.com/OD. Let's continue advancing patient care together, one episode, one innovation, and one patient at a time.